Good morning, everyone. It's a pleasure to be here. So these are my disclosures, some sources of grant support, and some consulting work. So this lecture was originally given as the Ostheimer lecture at last year's SOAP meeting. And the task of the Ostheimer is to summarize what's new in obstetrics and obstetric anesthesia over the previous calendar year, in my case, 2016. Well, it turns out there's a lot that's new that comes out each year. If you cross pregnancy in 2016 in PubMed, you'll identify 25,891 new citations. So how did I make sense of all of this new literature to present what's new? So across the year, I surveilled the contents of the highest impact anesthesia, obstetric, pediatric, and general medical journals, and then selected those articles that I thought were most important to the practice of anesthesia, obstetric anesthesia. So from that 25,000, 126 of the articles that I identified are summarized in a syllabus that'll be published later this year in Anesthesia and Analgesia. And then the lecture today will cover 23 of these articles. So just 0.1% of the total body of new literature that's been published, but a very carefully selected, and I hope you'll agree, important part. So we'll start off by talking about landmark RCTs, large, well-done RCTs that are very likely to change obstetric and obstetric anesthesia practice. We'll then talk about some studies looking at neuraxial anesthesia and pain control. We'll talk about studies that look at systems and systems-based improvements and their impact on obstetrical outcomes. We'll touch on a couple of new studies looking at anesthesia-related neurotoxicity. We'll talk about a couple of studies in the global health arena. And then we'll wrap up by talking about two pilot studies describing novel approaches to key obstetrical complications. So starting off with landmark RCTs, all of these deal in some way with prevention. Prevention of infection, prevention of postpartum hemorrhage, and the prevention of the complications of late preterm delivery. So the first study is by Alan Tita and colleagues, published in the New England Journal, looking at adjunctive azithromycin prophylaxis for cesarean delivery. So we know from epidemiologic studies that wound infection occurs in up to 12% of non-elective cesarean deliveries, and that ureaplasma species are commonly associated with these infections. However, ureaplasma species are not covered by standard antibiotic prophylaxis that we give at C-section, cefalozolins and clindamycin. So the investigators asked the question, does the addition of azithromycin, which covers ureaplasma well, to standard antibiotic prophylaxis decrease the risk of infections? The study was conducted at 14 centers across the U.S. They enrolled 2,013 patients undergoing cesarean delivery following labor or after membrane rupture. All received standard antibiotic prophylaxis, most commonly ANSEF, and then were randomized to azithromycin 500 milligrams or placebo. And the primary outcome was a composite of endometritis, wound infection, or other types of infection. So here are their results. So the addition of azithromycin was associated with about a 6% absolute reduction in the rate of their composite outcome, a pretty dramatic result. There was significant reduction in endometritis and wound infection, and a trend towards a reduction in other types of infections as well. There were also lower rates of the adverse maternal outcomes that you'd expect with the decrease in infection, including lower rates of postpartum fever, unscheduled clinic visits, readmissions, and the postpartum use of antibiotics. However, there are a number of important limitations that are relevant to interpreting the study. And the first is that 73% of the patients enrolled in the trial were obese. And it was not necessarily the case that the primary antibiotic, the cefalozolin, was dosed in a weight-based fashion. So it may be that the reduction that's being observed is due to the additive effect of azithromycin in the setting of inadequately dosed cefalozolins, and not due to broadening of the coverage to include ureaplasma species. Unfortunately, the study did not have culture data to show whether the addition of azithromycin resulted in a reduction in ureaplasma. So you might ask yourself the question, well, why not just add azithromycin? What's the downside? And as we saw, the results are pretty dramatic. Well, I think there are a number of important considerations in this regard. The first is here, as really across all of medicine, we need to be good stewards of antibiotics. We need to not introduce or overuse new classes of antibiotics if it's not necessary to avoid selecting resistant organisms. There are also certain adverse maternal effects associated with using azithromycin. There's been an association between azithromycin and an increased risk for cardiac arrhythmias. It's associated with GI side effects, an increased risk of C. difficile infection. And then there's another risk that we don't understand all that well, but that's the potential impact of broadening our antibiotic coverage on the infant microbiome. So there was a study in 2016 that looked at the impact of maternal intrapartum antibiotic exposure on the infant microbiome. This study, it was a study of 198 term infants that were part of the Canadian Healthy Infant Longitudinal Development Study. The investigators examined the infant microbiota, the commensal flora that populate the infant gut, at 3 months and at 1 year. And they found that the addition of, or treatment of the mother with antibiotics during the intrapartum period, whether for GBS prophylaxis or for cesarean prophylaxis, was associated with a dysbiosis, an imbalance in the commensal flora that populate the maternal gut, or the infant gut, rather. And this type of dysbiosis has been linked in other longitudinal epidemiologic studies with an increase in the risk of type 1 diabetes, asthma, allergies, and obesity. So I think whether to add azithromycin remains a debatable question. We clearly need studies where azithromycin is added in the context of appropriately weight-based dosing of the primary antibiotic. And we also need studies to better understand the long-term impact on the infant health of broadening antibiotic coverage. At our institution at the Brigham, we're using azithromycin in cases that are at the highest risk for postoperative wound infection, patients with morbid obesity, patients that had long labor with ruptured membranes, patients that are on immunosuppressants like steroids. So the second trial also deals with the prevention of surgical site infection, looking at the antiseptic agent used prior to cesarean delivery. So RCTs in other surgical settings have clearly demonstrated that chlorhexidine is superior to iodine for the prevention of surgical site infection. But surgical site infection following cesarean delivery is a little bit different in that it's due to both skin and vaginal pathogens. So the investigators here asked, is chlorhexidine superior to iodine alcohol for the prevention of surgical site infection? The study was conducted at a single center, Washington University in St. Louis. 1,147 women were randomized to chlorhexidine alcohol or iodine alcohol for skin preparation. And the primary outcome was a composite of superficial or deep surgical site infection. And what they found was the use of chlorhexidine was associated with about a 3% reduction in the risk of surgical site infection compared to iodine. It was a statistically significant reduction. And there was a trend towards lower rates of both of the components of the composite endpoint. And this finding makes biological sense. We know chlorhexidine has a number of properties that might account for its superior efficacy, including stronger binding to the skin than iodine, higher antibacterial activity against relevant species, and longer residual effects compared to iodine. Potential limitation of this study is that it was conducted at just a single center, always raising the question of generalizability. It was also impossible for the investigators to maintain blinding because of the difference in the consistency of the prep solutions and the color. That said, I think the large effect size that they observed merits transition to chlorhexidine. And we use chlorhexidine routinely for skin antisepsis, except in the setting of a stat cesarean delivery, where our obstetricians do an iodine splash. So while talking about chlorhexidine, I think it's also important to point out this warning that came out from the FDA about reports they were receiving of anaphylaxis to chlorhexidine. They received about 50 reports to the FDA's adverse events reporting system. And so they put out this warning that chlorhexidine exposure is associated with a rare but serious risk of anaphylactic reaction. I don't think this really changes the risk-benefit calculation as to whether to use chlorhexidine or iodine, but it is something that we need to think about if a patient has an anaphylactic reaction around the time of surgical start and include chlorhexidine on the differential of potential causative agents. So the next study deals with the question of prevention of postpartum hemorrhage. So we know from large RCTs done primarily in the developing world that misoprostol has uterotonic effects. There have been RCTs that have compared misoprostol to placebo for the prevention of postpartum hemorrhage, and here misoprostol was demonstrated to have efficacy. However, its role as an adjunct, as a second-line uterotonic administered on top of oxytocin, is much less clear. The largest study that we have looking at this question is this study by Widmer and colleagues published in The Lancet in 2010. And they took 1,400 patients who had postpartum hemorrhage, all of whom had been exposed to a first-line uterotonic, in most cases oxytocin. and then randomized them at the time of hemorrhage to either misoprostol 600 micrograms orally or sublingually or to placebo. And they found that the addition of misoprostol did not prevent the progression to severe hemorrhage to a greater degree than placebo, so it was not effective in that setting. This study asks a slightly different question. Does adding misoprostol earlier to oxytocin as part of the active management of the third stage of labor decrease the risk of postpartum hemorrhage? The study was conducted at 3 centers across France. It included patients with vaginal deliveries that occurred at or near term. All patients received oxytocin and then were randomized to either misoprostol 400 micrograms or placebo, with the primary outcome being postpartum hemorrhage defined as greater than 500 cc's of blood loss within 2 hours of birth. When they designed the study, they powered it to show a decrease in the occurrence of postpartum hemorrhage from 7.5 to 5%. And on the basis of this power calculation, they planned to enroll 3,100 patients. However, they conducted a planned interim analysis after they had enrolled 1,721 patients, and the trial was stopped due to evidence of futility as well as an unexpectedly high rate of adverse events in the misoprostol group. So here are the results. As you can see, there was no difference in the occurrence of postpartum hemorrhage between misoprostol or placebo, nor was there a difference in severe hemorrhage or hemorrhage in patients that were at high risk of postpartum hemorrhage. However, when they looked at the adverse effects that they were measuring, there was a much higher rate of fever, so 30% of the misoprostol patients had fever compared to 6% of the placebo patients, a higher rate of shivering, and then higher rates of GI, all of the GI side effects that were assessed, including nausea, vomiting, and diarrhea. So I think this study, coupled with the study from Widmer and colleagues, suggests a lack of effectiveness of adjunctive misoprostol, that is, misoprostol given on top of oxytocin. This, coupled with the unfavorable side effect profile associated with misoprostol, suggests that it likely has a limited role in the prevention of or treatment of postpartum hemorrhage in high-resource settings. In the developing world, where there's lack of access to refrigeration, to refrigerate oxytocin, or the ability to inject medications, misoprostol clearly has a role as a primary uterotonic, but as a second-line uterotonic, it doesn't seem to confer much benefit. The final RCT we'll talks about prevention of the complications of late preterm delivery. So for the past decade and a half, steroids have been considered the standard of care for deliveries that occur at less than 34 weeks based on randomized controlled clinical trial data showing a reduction in neonatal death, respiratory, and other complications of preterm delivery. However, we know from epi studies that late preterm delivery, those occurring between 34 and 36 weeks, the infants are also at higher risk of neonatal complications. So this trial asked the question, does betamethasone given to women likely to deliver late preterm to reduce the occurrence of respiratory or other neonatal complications associated with preterm delivery? The study was conducted at 17 centers across the US that were part of the Maternal Fetal Medicines Unit network. They randomized 2,827 singleton, non-diabetic pregnancies at 34 to 36 weeks gestation to either 2 injections of betamethasone 24 hours apart or to placebo. And the primary outcome was a composite of infant treatment for respiratory distress, stillbirth, or neonatal death. So here are their results. So with respect to the primary outcome, the administration of steroids was associated with about a 3% absolute reduction in the rate of this composite of respiratory complications, stillbirth, or neonatal death. There were significant reductions in severe respiratory complications as well as the need for infant resuscitation at birth. Looking at the adverse effects that they measured in the trial, the administration of steroids was associated with the higher risk of neonatal hypoglycemia, 24% in the betamethasone arm compared to 15% in the placebo arm. And this makes sense because the administration of steroids to the mother will result in a hyperglycemic response, which causes the fetus to upregulate its insulin secretion, and then following birth, when the maternal glucose supply goes away, the infant will have potentially a hypoglycemic response. And this is of concern because neonatal hypoglycemia has been identified as an independent risk factor for developmental delays. There's also been some concern raised in the literature about direct neurotoxic effects of steroids on the developing infant brain or fetal brain. So more data are needed regarding the long-term benefits and the risks associated with steroids administered for infants delivered late preterm. That said, SMFM, ACOG, the Royal College of Obstetricians and Gynecologists all now recommend steroids for pregnancies at risk for late preterm delivery. All right, we'll now talk a bit about studies looking at neuraxial anesthesia and pain control. We'll talk about a study that seeks to define the optimal dosing of intrathecal morphine, a study that looks at the utility of tap blocks, and then a couple of studies that look at the question of the untested catheter when placed as part of a combined spinal epidural. So the first study from Pervez Sultan and colleagues sought to define the optimal dose of intrathecal morphine for cesarean delivery. Most providers, based on a survey study that the authors of this manuscript did, use between 50 and 250 micrograms, so pretty wide range of the doses used, with 200 micrograms being the most commonly administered dose. So the objective here was to compare the duration of analgesia, the intensity of analgesia, and the side effect profile of low versus high dose intrathecal morphine. The authors conducted a systematic review to identify relevant RCTs that were studies looking at elective cesarean deliveries done with spinal anesthetics that compared low dose, defined as 50 to 100 micrograms, versus high dose, greater than 100 to 250 micrograms. They identified 11 studies with 480 patients that met their inclusion criteria, and then they combined these studies using standard meta-analytic techniques with continuous outcomes defined or described on the basis of mean differences and categorical outcomes on the basis of odds ratios. So here are the measures of analgesia that they assessed. So here the comparison is high versus low dose of intrathecal morphine. So the use of high dose was associated with a longer time to supplemental analgesia, on average 4.5 hours longer. However, when they looked at pain scores at 12 hours, pain scores at 24 hours, or morphine consumption across the first 24 hours, measures of analgesic effectiveness, those were not different between the high and the low dose group. So they then looked at the adverse effects associated with intrathecal morphine, comparing, and now the comparison is low versus high dose. So the reference group is high dose. So use of low dose intrathecal morphine was associated with the lower odds of severe pruritus, severe pruritus and vomiting, and a trend towards lower rates of the use of antiemetics. So the data show a modest difference in time to supplemental analgesia associated with the higher dose of intrathecal morphine, but no difference in pain scores or morphine use, what you might consider potentially more meaningful measures. There was a major difference, however, in side effect profile, with patients receiving high doses of intrathecal morphine having much more pruritus and nausea. And I think this study shows that for most patients, a lower dose of intrathecal morphine is preferred. However, there may be a subset of patients that are particularly high risk of pain after cesarean delivery or severe pain after cesarean delivery that would benefit from a higher dose. This was an RCT conducted by Jessica Booth and colleagues looking at two multimodal analgesic techniques in patients predicted to have severe pain after cesarean delivery. So these authors had previously defined a 3-question survey that could predict pain with movement on the first postoperative day. The survey questions looked at patients' baseline anxiety, their anticipated pain after the cesarean delivery, and their anticipated analgesic needs. And so the question for the study was, for patients at high risk for post-cesarean delivery pain, does high-dose intrathecal morphine plus acetaminophen provide better pain relief than low-dose intrathecal morphine? They enrolled 60 patients that were found to be above the 80th percentile on the basis of their survey questionnaire. And those were randomized to 300 micrograms of intrathecal morphine plus a gram of acetaminophen Q6 hours for the first 24 hours, or 150 micrograms of intrathecal morphine. All patients received a morphine PCA as well as ibuprofen. And the outcomes assessed were pain scores at 24 hours, so pain with movement, at rest, on average across the first 24 hours, and the worst pain measure across the first 24 hours. And then based on a prior work that's shown an association between poorly controlled pain in the immediate post-delivery period and persistent pain and depression, they also surveyed their patients at 8 weeks with respect to those endpoints. So here are their results. So the blue bars show the low dose of intrathecal morphine. the red bars, the high dose of intrathecal morphine with acetaminophen. And as you can see, the high dose acetaminophen group had lower pain scores with movement at rest and on average across the first 24 hours. There was no difference in the worst pain scores, although the authors note that the worst pain tended to occur with fundal massage, quite a stimulating intervention where you wouldn't expect the difference in intrathecal morphine to necessarily have an impact. Looking at the adverse effects that might be associated with a higher dose of intrathecal morphine, there was perhaps a slight trend towards lower rates of pruritus in the low dose group, a small difference in the point estimates with respect to nausea. And then when they looked at persistent pain and depression, there was no difference between the two groups, although they note they were significantly underpowered to look at that endpoint. So this trial suggests that high-risk patients, those predicted to have severe postoperative pain, may benefit from a higher dose of intrathecal morphine. A major limitation or challenge to the interpretation of this trial is that really two interventions occurred, the addition of acetaminophen as well as the addition of a higher dose of intrathecal morphine. And so it's not really possible on the basis of these data to disentangle the relative contributions of each of those changes, and we'll need future studies to disentangle them. So if you wanted to implement a change in your practice on the basis of these findings, you'd really want to use both components of their intervention. So the next study is a meta-analysis looking at the clinical effectiveness of transversus abdominis plane blocks, TAP blocks. So TAP blocks are a peripheral nerve block that anesthetize the nerves of the anterior abdominal wall. These authors meta-analyzed all the available RCTs looking at TAP blocks after cesarean delivery, and they took the pain scores from those studies and translated them to an 11-point numeric pain rating scale, so a pain scale from 0 to 10, and all of the results I'll present are on that 0 to 10 scale. They divided the trials into three groups based on the comparisons that were being made. The first group were studies looking at TAP blocks versus sham or placebo blocks in patients who did not receive intrathecal morphine. The next group of trials were a comparison of TAP blocks versus intrathecal morphine, so TAP blocks versus intrathecal morphine head-to-head. And then finally, they looked at trials that compared TAP versus sham or placebo blocks in patients, all of whom had received intrathecal morphine. So the first group of trials, TAP versus sham or placebo block in those that didn't receive intrathecal morphine, they found that the use of TAP blocks was associated with a significant reduction in pain scores at rest at 6 hours and with movement at 24 hours, and a trend towards lower pain scores with movement at 6 hours and at rest at 24 hours. When they looked at studies comparing TAP blocks head-to-head with intrathecal morphine, the use of TAP blocks were associated with a higher pain score at all the time points measured, both with movement and at rest, compared to intrathecal morphine, suggesting that intrathecal morphine is more effective for analgesia than TAP blocks. And then finally, the trials that compared TAP blocks versus sham or placebo blocks in patients, all of whom received intrathecal morphine, they found a very small reduction in pain at rest at 6 hours and pain with movement at 6 hours, but no difference in pain scores looking out at 24 hours. So these data show, based on the available RCT data, that TAP blocks are inferior to intrathecal morphine for post-cesarean pain control, but superior to sham or placebo, and probably of little benefit when added to intrathecal morphine, when done on top of intrathecal morphine. So I think this is really helpful in thinking about the clinical utility of TAP blocks. I think they're potentially useful if a patient can't receive intrathecal morphine. For example, if a patient had a general anesthetic or if they have some contraindication to receiving NEURAXIAL narcotics. I think going forward, there's going to be a need to define with studies whether there's benefit of these blocks in opioid-tolerant patients. That's a setting where we will routinely use TAP blocks if patients have likely resistance to the effects of intrathecal morphine because they're on buprenorphine or methadone or are on chronic opioid therapy. There's also going to be a need to define whether there's benefit with longer-acting local anesthetics like liposomal bupivacaine, or whether there might be benefit when TAP blocks are provided along with TAP catheters where there can be continuous infusion. The next two studies look at the question of the untested catheter in the setting of combined spinal epidurals. So we know that CSCs offer certain advantages over traditional epidural technique, including a faster onset of labor analgesia. But there's long been concern raised in textbooks and review articles about using CSCs in patients at high risk for cesarean delivery because of this question of the untested catheter, the notion that if the spinal component of a CSC might mask a poorly functioning epidural catheter that may then go on to fail at the time of cesarean delivery. So this study asked the question, is the recognition of failed catheters delayed by the use of a CSC technique compared to traditional epidural technique? It was a single-center retrospective cohort study conducted at Wake Forest based on anesthetic, obstetric, and QA records. They identified 1,440 CSC patients and 955 traditional epidural patients. The primary outcome that they defined for the trial was the rate of catheter failure during labor. And then secondary outcomes they assessed included the cumulative proportion of catheters that failed, the time to failure, and then failure at cesarean delivery. So this is their primary analysis showing the failure rate of catheters over time. And as you can see, the CSC group has a lower failure rate at all the time points assessed compared to the epidural group. And this is reflected in their hazard ratio. The use of CSCs had a hazard ratio of 0.58 for catheter failure compared to traditional epidural techniques, suggesting they fail at a lower rate than traditional epidurals. When they looked at the overall proportion of catheters that failed, it was much lower in the CSC group compared to the traditional epidural group, about half the rate of overall failure. Interestingly, the time to failure was shorter in the CSC compared to traditional epidural group. And then perhaps most importantly and most clinically meaningfully, the failure rate at cesarean delivery was also significantly lower in the CSC compared to the traditional epidural group. A similar study was conducted by investigators from Columbia and the University of Miami. They looked at the rate of catheter replacement in catheters placed as part of a CSC versus an epidural and found, as in the prior study, the rate of replacement was lower in catheters that are placed as part of a CSC compared to traditional epidural, and they observed no difference in the failure rate at the time of cesarean delivery. So I think taken together, these studies debunked concern that's been raised historically regarding the untested catheter. If anything, catheters that are placed as part of a CSC tend to fail less. And that makes sense because you know where you are. When you get the CSF back, when you try to place the spinal component, you can feel fairly certain that the catheter you thread is going to be into the epidural space. All right, the next group of studies we'll talk about look at systems and their impact on obstetrical outcomes. We'll talk about a study looking at the impact of OR temperature on neonatal and maternal hypothermia. We'll talk about a study looking at the impact of obstetrician cesarean, annual cesarean volume and various C-section related outcomes. So the first study is a randomized controlled clinical trial. We know neonatal and maternal hypothermia are common at the time of cesarean delivery. And neonatal hypothermia in particular is associated with a range of really serious complications, including neonatal hypoglycemia, metadolic acidemia, interventricular hemorrhage, respiratory distress, and even a neonatal death. As a consequence of this association, the World Health Organization recommends that operating rooms where deliveries occur be maintained at a temperature of 77 to 82 degrees Fahrenheit. Yeah, yeah, exactly. I mean, no one's going to tolerate temperatures this high. So the objective of this study was to determine if increasing the OR temperature just a bit, not to the range that the WHO recommends, but within a range that practitioners are likely to tolerate, will result in a decline in neonatal or maternal hypothermia and associated morbidity. It was done at a single center in the US, Parkland Hospital in Dallas, where they do a really large volume of deliveries. It was a cluster randomized RCT in which the operating room temperatures were adjusted on a weekly basis between 67 degrees Fahrenheit, which is their institutional standard, and 73 degrees Fahrenheit. And the primary outcome for the trial was neonatal hypoglycemia on admission, neonatal hypothermia on admission to the nursery. And then secondary outcomes assessed included various measures of neonatal morbidity and maternal hypothermia on admission to the PACU. So here are the results. So as you can see, turning the OR temperature up just 6 degrees Fahrenheit to 73 degrees Fahrenheit was associated with a marked reduction in the risk of neonatal hypothermia from 50% to 35%, and a reduction in severe hypothermia from 19% to 5%. Pretty dramatic results. When they looked at various neonatal complications that might be associated with hypothermia, they did not observe a statistically significant difference across any of those measures, although the authors note they're markedly underpowered to detect clinically important differences in these relatively rare outcomes. Maternal hypothermia was also less common when they used the higher temperature, 77 versus 69%. So this study shows that a modest increase in OR temperature can have a marked effect on neonatal temperature. The authors note that a very large trial, perhaps an impractically large trial, would be required to conclusively demonstrate differences in measures of neonatal morbidity associated with hypothermia, but given the strong association we know between infant neonatal hypothermia and adverse outcomes, they make the argument that we really should increase our OR temperatures to at least 73 degrees Fahrenheit. The next study looks at the impact of surgeon annual volume on short-term maternal outcomes following cesarean delivery. So operator volume has been shown to correlate with morbidity and mortality in many high-risk procedures. And this has really led to a change in the way certain surgical subspecialties are practiced, with high-risk cases and triage to centers where they do a large volume of those procedures. This association has not previously been examined for cesarean delivery. I think it's long been thought that any well-trained obstetrician should be able to safely perform the relatively straightforward surgical procedure of cesarean delivery. But the authors asked the question, does a surgeon's annual volume of cesarean delivery impact on short-term maternal outcomes? It was a retrospective study, cohort study, done at a very high-volume center in Israel. They calculated up the annual number of cesarean deliveries performed or supervised by each of their obstetricians. They found the median number was 48, and then they dichotomized their faculty into two groups. So a low-volume group where they did less than 48 cesarean deliveries each year, and a high-volume group where they did 48 or more. And the primary outcome was a composite measure of adverse outcomes that could plausibly be related to surgical skill. So here are the results. So having a cesarean delivery performed by a high-volume surgeon was associated with a 17% reduction in the primary outcome, their primary outcome measure, this composite adverse outcome. That's a composite of all of the complications that you see listed below. There was a significant or trend towards significant reduction in the rates of urinary or GI tract injuries, hemoglobin drop of greater than 3 grams per deciliter, prolonged hospitalization, relaparotomy, and readmission associated with having a high-volume surgeon. They then redid the analysis using volume quartiles, looking for a threshold effect, seeing whether there might be some minimum number of surgeries that the obstetrician had to perform where outcomes would start to become equivalent. And in fact, they didn't observe any threshold. The more surgeries the obstetricians performed, the better the outcomes. The limitations of this study are it was done at just a single center, so it's going to need to be replicated in a larger sample. There's also a potential for confounding, and as with any observational study, but the authors point out, if anything at their center, the more complex surgical cases get triaged to the high volume providers. I think if these findings are replicated and play out across other settings, it could have important implications for approaches to staffing of labor and delivery units, where rather than private practitioners coming in and doing just a couple of cesarean deliveries each week or each month, labor floors will be staffed by laborists who are real specialists in managing patients who are laboring, and as well as cesarean deliveries. So we'll now talk a little bit about anesthesia-related neurotoxicity. This is a big topic, and we'll touch on just a couple of important issues. The first is an FDA warning on neurotoxicity that came out in 2016, and then 2 studies evaluating the long-term impact of anesthetic exposure in children that also came out during that year. So in 2016, the U.S. Food and Drug Administration issued a warning that repeated or lengthy use of general anesthetic and sedation drugs during surgeries or procedures in children younger than 3 years of age or in pregnant women during their 3rd trimester may affect the development of children's brains. And I think we can question what the clinical impact of this warning is. We don't do elective surgeries in women who are in their third trimester of pregnancy. That said, this warning did get a lot of attention in the press and has on the part of patients and providers. And you know, it's interesting, at the same time as this warning came out, really the two highest quality studies that have been done in humans looking at the potential for anesthesia-related neurotoxicity were published. And the first is this trial that was published in The Lancet in 2016. It's the GAS trial. It's an international, multi-center, randomized controlled clinical trial where infants with inguinal hernias were randomly allocated to having their hernia repaired via an awake regional technique or a sevoflurane-based general anesthetic. The primary outcome for the trial is going to be full-scale IQ testing of the children at age 5, and that still has not been reported. This is a report of a secondary outcome of the trial, neurodevelopmental outcome at 2 years of age, assessed with the Bailey Developmental Index. But as you can see, there's absolutely no difference between the two groups in the measures of neurodevelopment in either the regional or the general anesthetic group, suggesting the general anesthesia was not neurotoxic in this setting. The second trial was published or the second study was published in JAMA. It comes from the Columbia group. They took a slightly different approach to answer a very similar question. So they took 105 infants that underwent a single anesthetic exposure, again for inguinal hernia repair, and then as a way of controlling for confounders, matched them to their siblings who were not exposed to general anesthesia during the early years of their life, and brought the kids in for IQ and other intellectual performance testing. And they found there was absolutely no difference in IQ tests. In fact, the mean IQ was the same and high in each of the two groups, again suggesting that general anesthesia was not neurotoxic in this setting. So while we know from studies in animal models, anesthetic agents have the potential to be neurotoxic, particularly when given over a long duration and with multiple exposures, the highest quality human data that we have to date, these two studies that I just presented, are quite reassuring. Limitations of the new human data are that the duration of anesthetic exposure is very short, and we also don't have comparable high-quality data for in utero exposure, so we need to extrapolate when counseling patients based on what's been observed in studies on young infants. So I now want to talk about a couple studies in the global health arena. The first is a study looking at maternal mortality, and the second study looking specifically at anesthesia-related maternal mortality in low-resource settings. The first study is from the Global Burden of Disease group. This is a group that endeavors to measure rates of disability and death worldwide. It's run out of the Institute of Health Metrics and Evaluation in Seattle, but engages with 1,800 or so researchers from more than 120 countries when conducting their studies. They systematically compile and process all available data to estimate measures of disability and mortality, and in this report, report the maternal mortality rate from 1990 to 2015. So this is a figure from their study showing the rate of maternal mortality per 100,000 live births from 1990 to 2015. And as you can see, there started to be an inflection point around 2000. And between 2000 and 2015, there was a 30% reduction in the rate of maternal mortality. And this is attributable largely to increased medicalization of births in low-resource settings, so more births occurring in hospitals or clinics where there's access to medical care rather than home births, as well as a higher mean maternal age in certain countries at the time of first pregnancy. And while this is really good news, the fact remains that at the most recent estimate in 2015, there were 288 maternal deaths, the vast majority of which could have been prevented with better medical care. It's a sobering statistic. And if you look at the maternal mortality rate between countries, this is a map, color-coded map showing the rates of different countries where red and orange have the highest rates. There's about a 40 to 50% or 40 to 50-fold variation in the rates of maternal mortality from the countries with the lowest maternal mortality rate to those with the highest rates, with certain countries in sub-Saharan Africa, Afghanistan, certain parts of South Asia having remarkably high rates, where rates as high as maternal death for every 100 or 200 births. And when we look at why women are dying in 2015, this shows the proportion of maternal deaths attributable to various causes as a function of maternal age. And as you can see, across all of the maternal ages assessed, hemorrhage and hypertension were the most significant contributors, together accounting for about half of maternal deaths, emphasizing the need to develop more effective interventions to address these complications. So this next study looks at anesthesia-related maternal mortality, specifically in low and middle income countries. It was a systematic review and meta-analysis that sought to define the rate of maternal mortality attributable to anesthesia, as well as factors related to this outcome. They pooled data, the investigators pooled data from 140 published studies to make their estimates. And what they found was that anesthesia overall contributed to about 3% of maternal deaths. But if you look at patients that underwent an anesthetic, for example, patients who had a cesarean delivery, the rates are much higher. So for patients that had cesarean delivery, anesthetic death accounts for about 14% of maternal deaths, translating to about 1 maternal death per 1,000 women undergoing a cesarean delivery, which is, again, a staggering statistic when we think about how safe obstetric anesthesia is in the settings where we all practice. When they looked at the risk factors for anesthesia-related maternal death, it was more common in patients that underwent general versus regional anesthesia, more common when there was a non-physician anesthetist. I think this paper really points to a tremendous disparity in the safety of obstetric anesthesia and a real need for all of us to think about ways in which we can support our colleagues working in low-resource settings in terms of education or help with practice improvement to address this tremendous disparity. So I'm going to close with talking about 2 pilot studies that describe novel interventions to treat key obstetrical problems. So we talked a minute ago about how hemorrhage and hypertensive disorders are the main contributors to maternal mortality worldwide. So the pilot studies address each of these complications. So the first is a study of a new device to cause vacuum-induced uterine tamponade. So clearly there's a need for low-cost alternatives to control postpartum hemorrhage. In low-resource settings, uterine packing has long been used to treat postpartum hemorrhage, but it has the disadvantage of concealing the bleeding, so it's hard to assess how much bleeding is occurring, as well as incomplete efficacy. So these investigators developed this relatively simple device. You can see it diagrammed here. There's a distal loop with pores, an occlusion balloon that sits in front of the cervix, a valve for inflating the occlusion balloon, and then a vacuum port. And this shows the device deployed. So the occlusion balloon sits in front of the cervix, the pores, the loop with pores sits in the uterus, and then a vacuum is applied that causes the uterus to collapse on itself. So you've all been in cases where the obstetrician does B-Lynch sutures, causing the uterus to compress on itself. This is sort of doing the same thing, but internally by generating a vacuum. So in the study, the investigators reported a prospective proof of concept investigation. They took 10 women with postpartum hemorrhage who had failed first-line therapies, uterotonics, and when they deployed this device, they found that the bleeding stopped in all patients. The benefits of this approach is that it's rapidly deployable, it's inexpensive. Because the blood that's accumulating in the uterus is under suction, you can monitor ongoing blood loss, and it can be readily used in low-resource settings as long as there's access to a vacuum. Large trials are going to be clearly needed to more conclusively demonstrate the value of this approach, but I think it's an exciting innovation that could have an important public health impact worldwide. The next study looks at a novel approach to the prevention of preeclampsia. So we currently don't have a highly effective therapy to prevent preeclampsia. We know that preeclampsia from basic science work is a disease of endothelial dysfunction and inflammation. It has a lot of similarities to cardiovascular disease. And statins have been demonstrated to restore endothelial function in animal models of preeclampsia. And based on these animals, these investigators, animal model studies, these investigators conducted a pilot multi-center double-blind RCT. They took 20 women with a history of severe preeclampsia and a prior pregnancy that were delivered at less than 34 weeks, so a group that's at very, very high risk for having recurrent preeclampsia. And then they randomized them between 12 and 16 weeks gestation to pravastatin or to placebo. There were no safety concerns that were identified in the trial. There was a decrease in maternal cholesterol, as you would expect with treatment with the statin, but there were comparable infant birth weights in both groups, and umbilical cord concentrations were also similar in both groups. They measured levels of an anti-angiogenic factor, SFLT, that is predictive of developing preeclampsia, and plotted those in patients that received placebo and pravastatin. The blue lines are patients that received the placebo, and the red lines, those that received pravastatin. And as you can see, the levels of SFLT tended to be higher in those that received placebo compared to those that received the statin. When they looked at outcomes, in the placebo arm, 4 out of the 10 patients developed preeclampsia, 3 with severe features. Those treated with statins, 0 out of the 10 developed preeclampsia. And this was a statistically significant difference in this very small pilot study. So clearly, we're going to need larger trials to see if this holds up. But the safety observed in this pilot study, as well as the really marked difference in outcomes, I think favors a future study. And this, again, has is a very promising approach to deal with this critical obstetrical complication of preeclampsia. So I'm going to close with a proposed to-do list. So in my house, every Saturday morning, there's a to-do list that we start the day with. And so I think this is appropriate for this Saturday morning. This is a list of things you can take back to your labor and delivery units based on the data that we've reviewed here. And think about implementing in your practice. And the first is consider adding azithromycin for cesarean delivery in high-risk patients on the basis of the trial from Tita and colleagues that we talked about. If you haven't already, transition to chlorhexidine as the usual antiseptic agent used prior to cesarean delivery. Avoid the use of misoprostol. We now have several studies that demonstrate that misoprostol does not add anything above and beyond first-line uterotonics oxytocin and is associated with quite an adverse side effect profile. Consider using low-dose intrathecal morphine for most of your patients on the order of 100 micrograms. Turn up your OR temperatures to at least 73 degrees Fahrenheit. And then find ways to contribute to efforts aimed at supporting obstetric anesthesia practice in low and middle income countries with either your time or your money. So with that, I am happy to, I think we're having the panel. So thanks very much for your attention.